Our objectives for today, however, are in a much broader sense. We want to give you guys an idea about what sleep apnea is, how to identify it. We want to look at how it's diagnosed, who does that. We want to talk about basic definitions. We're going to throw around some acronyms, AHI and RDI and things like that. We want you guys to get that and understand what that is. We're going to talk for a few minutes about obesity and how that affects this. We're all getting fatter, and how does that affect sleep apnea? We're also going to give you guys some homework, and we're going to talk about where we can go from here.
1 in 5 and 1 in 10. Well, what does that mean? Get a pad of paper out and a pen and jot down the number of active patients you have. If you think about it or just think of them in your mind. Now take that number and times it times 0.2, or 1 out of 5 of them have at least sleep disordered breathing. And the sad part about that is only 1 out of 10 have been successfully treated. We're here to help them. You're here to help them. We hope that we all help them together.
When you see patients in your practice for the first time, you like to go over their medical history. When you look at the problems, the medical diagnoses that they have, you're going to see a lot of these same types of things come up. How many people have depression, reflux disease? Morning headaches is a big one. Obviously snoring, how I'm sleeping, if I'm not sleeping well. I have daytime sleepiness. Mentation issues. I had a guy tell me the other day, I just want to have the same thought process from the morning until the evening without that brain fog that I get when I'm tired. We need to be reviewing medical histories, but when we see these types of things, we need to understand that there's a very strong correlation and crossover between these types of problems and sleep disordered breathing.
Understanding that a lot of problems are caused from sleep disordered breathing. As a matter of fact, that we don't even have a slide for, but along what you were saying there, Rich, is that people who have obstructive sleep apnea utilize the healthcare system to twice the dollar amount annually because they're getting treated for all these other problems. And they're seeing their physicians, and they're not getting it sometimes. Who do you think's in the best position to help these patients who don't know they have this problem, or the patients who maybe know it and need another solution? Well, we think the solution is the dentist, and there's really not any argument against it if you really understand what goes into identifying these patients. You need a good health history. You need to ask some questions. Well, we do that every day. Well, what else do dentists do? We spend more time with our patients than physicians do annually, by a long shot. We have time to talk to them. We intimately know our patients better. We are absolutely in the best position to identify these people. On top of all that, we get to look in their mouths. We see their tongue. We see their oral anatomy. We see their anatomical anatomy, which has a lot to do with whether they're susceptible to sleep disordered breathing or obstructive sleep apnea. We truly are in the best position to identify these patients. It takes not much longer than it does to do an oral cancer screening. And every time when I do lectures across the country, I ask the question, how many oral cancers did you find last year? The most I've seen in this past year was 4. I can tell you're going to have 4 patients in your office on Monday or Tuesday or Wednesday, whatever day of the week it is. Every day you're going to have near that many. So if you want to help people, start doing your sleep disorder breathing screenings.
Good point.
The American Academy of Sleep Medicine has what they call the practice parameters. And now this isn't the dentist. This is the American Academy of Sleep Medicine. So it's the physicians group. And basically what the practice parameters are is the standards of care, how we should practice medicine. And in 2006, a huge change helped dentists out. It really put us on the runway in this jet that's getting ready to take off. And basically what they said, it was oral appliances are indicated for use in patients with mild to moderate OSA who prefer them to CPAP, or who do not respond to, or who are not appropriate candidates, or who failed treatment attempts with CPAP. And normally I don't like reading slides, but that's important enough to read. And if you want to read that yourself and then think about what that means. Essentially what that means is anybody who has mild to moderate apnea should be given a choice between a CPAP or a dental sleep device or oral appliance, whatever you want to call it. And anybody who can't tolerate CPAP, which is a significant number, should be given a dental appliance.
Or at least be given the option of that. And that's why we're here doing what we're doing, to get the word out and to educate not only the dentists, but the physicians as well. And let's not forget about the patient. That's the one who can benefit the most from this. And we feel like if you keep the patient's best interest at heart, you can't get too far off.